All right, Dr. Customer, I think we're ready.
All right, good afternoon, everyone. This is the Protocols, Medications, and Devices Standing Committee meeting of July 21st at 1200 hours. We'll go ahead and call the meeting to order. Shelley, can you start the roll call, please?
Sure. Amber Rice. Present. Erin O'Connor. Brian Smith.
Present.
Erin just joined. Okay. Just advise Erin to join. Hester Key. Bronco Castellarin.
Present.
Dark Gamer.
Present.
Heather Miller.
Present.
Jason Johnson.
Here.
Josh Gaither.
Here.
Mark Hansen.
Here.
Thank you. Matt Shaw.
Here.
Paul Dabrowski. Philip Hannon.
Present.
And Shari Brand.
Present.
I count 12. We have quorum.
Hey, Shelley, do you want to do the housekeeping announcements?
Sure. Everyone, please be advised that this meeting is being recorded and will be posted publicly. So anything said in the chat or verbally or seen on video cam could become part of the recording.
And I will just add, the last two meetings, there were apparently some audio issues if you were joining virtually. If you're having difficulty hearing us, if you use your headset, the audio does tend to be better. So that is an option if you're having any audio difficulties on the online meeting.
All right, so we'll go ahead and start with the chairman's report, beginning with the attendance record. That is attachment A. Friendly reminder that if you miss 2 consecutive meetings, the Bureau will contact you to ask you if you're still interested in serving on the committee. We also have the opportunity to welcome 2 new members, Mark Hansen from Ames, as well as Philip Hannon, Dr. Philip Hannon from Southern Arizona EMS Committee. Welcome to both of you. Vacancy report, there are no vacancies to report at this time. Bureau report, Chief Garcia.
Good afternoon, Dr. Castro-Marin. Some quick Bureau updates. In the interest of time, I'll just say that the Department of Health Services is looking at a new licensing management system that will replace our current online certification system for EMCTs. We will use these meetings as well as the regional council meetings to provide updates on the progress of implementation of a new system. We'll also keep everybody in the loop on any updates related to the trauma registry and Arizona Peers as that EPCR system migrates to NEMSIS version 3.5. Again, in the interest of time, we won't go over legislative or rule updates today. We will come back to the EMS Council meeting in September to share more comprehensive legislative and rule updates related to EMS and trauma. As this group reviews the T3Gs, if there are any questions or comments particularly related to treat and refer guidelines, we would like to hear from the committee members if there's anything especially related to new legislation where we can clarify any of the treat and refer guidelines. We look forward to continuing those conversations. We want to thank briefly Dr. Jessica Bell, who is on the line from ADHS, who has worked on our Arizona suicide prevention plan. I know she's going to share a few things related to the 988 implementation here in Arizona. But before we do that, I will turn it over to Dr. Bradley.
Thank you for joining us this afternoon. I will keep this brief as we do have a very busy agenda today. Just a reminder that we do have the resources available for the Naloxone Leave Behind program, as well as a link to the ADHS opioid webpage. There are quite a few resources if you are interested, and we did mention this earlier today, but in the interest of time, we will keep that brief for this meeting. So thank you.
Yes, and Jessica, are you on the line to share a few items related to 988?
Yes, I am. Thank you. Thank you so much for allowing me to provide a really brief update this afternoon. As you hopefully are already aware, on July 16th, the 988 Suicide and Crisis Lifeline, that was formerly known as the National Suicide Prevention Lifeline, went live across the country. This line offers 24/7 call, text, and chat access to trained crisis counselors who can help people that are experiencing suicidal, substance use, and or mental health crises, or any other kind of emotional distress. And people are also able to dial 988 if they are worried about a loved one who may need crisis support. And these operators are trained to provide conversational support and can connect callers to local services and dispatch mobile crisis teams if the situation requires in-person assistance. While this 3-digit number will make it easier for individuals in the general public to remember, which we hope will increase utilization for support during a mental health crisis and to help prevent suicide in Arizona, we already actually have a lot of local crisis resource lines available. And these crisis resource lines will continue to be operational and should be utilized by providers in the field as they have been previously. So there are no changes to the current crisis lines or protocols that we know of at this time, and we'll continue to provide any updates as they are received from our sister agency at Access. And that is my update. Thank you so much.
Thank you, Dr. Bell. We appreciate it.
Thank you very much, Dr. Bell, for that very important information. We're all very excited to see how this blends into our current resources, and certainly hope it'll make a positive difference for our communities. On to discussion and action items. The first item to discuss will be requesting a motion for approval of the minutes from our meeting on March 17th, 2022. That's attachment 5A. Can I have a motion to approve these minutes?
So moved.
All right, in the room we have Josh.
Second.
And Amber Rice.
All right, it's been moved and seconded to approve the minutes from March 17th. Is there any discussion or any amendments needed? Correction? Hearing none. All those in favor to approve the minutes, say aye.
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 All those opposed, say nay. All right, the motion is carried to approve the minutes from March 17th. Thank you. The next item is to discuss, amend, and approve the draft minutes from the special meeting on June 16th. That is attachment 5B. That covers the T3G content that has been reviewed. Can I get a motion to approve these minutes?
A motion to approve. I'll second.
All right, it's been moved. Thank you. It's been moved and seconded to approve the minutes from June 16th. Any discussion? Hearing none, can we get a vote? All those in favor to approve the minutes from the special meeting on June 16th, say aye.
Aye.
Any opposed, say nay. And the motion carries to approve the minutes from June 16th. All right, the next item on the agenda is to discuss, amend, and approve additional T3G content. Can I get a motion?
So moved, Brian.
Second.
Matt in the room is second.
All right, thank you. Let's go ahead and open discussion for the additional T3G content.
Do you want to pick up where we left off?
Yes, I'm showing that we've got one more airway guideline to approve.
Okay.
So I think, Dr. Riley, this is from the central region, the RSI? STR?
Sure. So this is one of the guidelines that the central region has in place using the format of the TTTs for RSI for agencies that have the STR in place. So the group has voted to consider adding this in. Would be clearly labeled as the STR that is not changing with the basis on this. So Matt, thank you very much for taking the time to review it. If you want to go over your thoughts and recommendations.
Yep. I thought. Largely, I thought the STR looked just fine. I think there was some, my questions were on the dosing regimen for the different medications. I thought it did a good job of discussing pre-oxygenation and optimizing the patient as best as possible prior to dosing the medications, using apneic oxygenation. The doses for the etomidate and ketamine seemed in line with what I found. My question, or my recommendation was the rocuronium dose was previously listed as 1 milligram per kilo. And my recommendation was 1.5 milligrams per kilo, based on a recent paper that was published, Canadian Journal of Emergency Medicine, that looked at different rocuronium dosings and their effect on first pass success. It looked at doses less than 1 milligram per kilo, 1.2 to 1.3, and then greater than 1.4. And 1.4 showed by far and away a better first pass success rate than the lower dosing did. So that was my recommendation.
So just for awareness on this one, in the central region, the current dosing, if you can scroll back up just a little bit on that one, for rocuronium is 1 milligram per kilogram. That is the current dosing that is in place in the central region. I think there's only one agency that I'm aware of that utilizes rocuronium ground unit.
The only other thing I would add to that discussion is 1.5 milligrams is a big dose. That's a lot of vials of rocuronium. So
Typically 2 for the majority.
yeah, it depends on how big. Yeah.
Hi, it's Brian. I have one question real quick. Why only under rocuronium does it require agency medical director approval? Because this whole thing requires that. It seems redundant to have that specifically noted with rocuronium.
The background of that for the central region, when this was formed, like I said, there was only one agency and one medical director in the central region that utilizes rocuronium, and they wanted that to be very clear, so that if an agency in the central region, that the agencies run automatic aid, and so you have a lot of border units that may run together. They wanted to make it very clear that if you had 2 different units from 2 different agencies running together, that there wouldn't be someone utilizing rocuronium if not approved by their agency and medical director. So that's why for that one it was specified, just due to the automatic aid system and the amount of kind of cross-pollination you sometimes get on a single call.
Edit to remove that.
And that's, I think, a board discussion.
It's Brian again. I actually do have one more thing to add. Under the line for EMT, there should be a / or whatever and say AEMT also.
Well, the way that would be formatted is that it would have its own colored bar adjacent below, correct?
Correct.
You could do that.
So my inclination, but again, up to the group to decide, would be to keep the rocuronium dose at 1 milligram per kilogram. I think that's typically what I use in the hospital setting. I don't know if anyone else wants to speak to that dosing.
That's what we would use in ED2. Usually 1.2 to 1.5, so I've seen 1.5 kind of more frequently.
It's Aaron O'Connor. I actually use even lower dosing, 0.6 milligrams per kilogram, but that's in an ICU setting and in the emergency department setting. But I wasn't aware of the recent study that came out indicating higher dose. I'd have to look at that literature, but I would favor 1 milligram per kilogram.
Like if I may, like a lot of the original studies when they were looking at, right, they usually use 0.6 for rock, but the big issue with that was at that point, the whole sucks versus rocks debate was it's lower onset. How do you negate that? You double rock. So that's why the minimum 1.2 was always kind of the teaching, and the concern being that you start going lower, you're just running into the same issues you would when rock was just not acting as quickly. So I think especially like in the field, you have one chance. You know, I know there's field airway ways to go, but to do the best we can to maximize first attempt. So I'm leaning more towards 1.2, 1.5. So.
Also gives you 3 medications with the same milligram per kilogram dosing, which might be a little bit easier to call the 3 different doses.
In the chat, Chris Ramos indicated PCH uses 0.6 to 1.
Well, people ponder that. Do you want to go over the other discussion items in that?
Forgive me, I don't remember what else there was. I feel like the drugs were not the primary.
I think that was, I'm just pulling up the original. You can scroll down a little further.
Was sedation drugs on it, okay.
All looks the same, so that was the only recommended update.
We want to do it as a range, 1 to 1.5, like you did down on the post-intubation where you gave ranges. Or do we want just a hard number?
I think a hard number for something like RSI would probably be beneficial versus range for your initial induction dosing.
In the chat, also Shari Brand, 1.2.
This is Franco. Does anybody want to consider a specific vote to amend the dose as it's shown as 1.5? Does anyone want to just do an up or down vote to amend it to 1 milligram or some alternate dose and start there?
Chat, Mark added as an in-field provider, same dose protocol would make it easier to remember.
Can I ask a silly question? I apologize. Full disclosure, we don't do RSI in Southern Arizona. This is not my area of expertise. What's the evidence base for making it 1.5? I haven't seen that, and I want to take a quick peek at it.
So it was published in the Canadian Journal of Emergency Medicine. It looked at 8,000 patients who received RSI and then broke it down.
What's the name of
the article? Sorry, yeah.
Did you link it in yours? I thought it was on there.
Yeah, it's the Association of Rocuronium Dosing and First Attempt Intubation Success in Adult Emergency Department Patients.
The PD study.
Yeah.
And is anyone familiar enough with the pharmacology of rocuronium to talk about how the dosing affects its time to onset and duration of action and all that type of stuff?
It's Aaron. I mean, the implication is the higher dose, you have a more rapid onset of action, I guess, but I haven't looked at pharmacokinetic data to substantiate that. I do know that we see prolonged duration of action with higher doses compared to the lower dosing, which is why my personal practice was always to block the lower dose of 0.6. But obviously, we're in the field and we're in other extenuating circumstances, so I will defer.
I think that's the concern sometimes when we extrapolate hospital data to the pre-hospital setting. In a hospital setting, you have usually a lot of backup. So if the airway does not go well, you hopefully have anesthesia or other backup available. In the pre-hospital setting, you may have absolutely no backup. And so if you have a prolonged transport time and an unsuccessful airway, you are now going to have to manage that patient with background ventilation and hopefully an OPA. So I think that's just something for consideration. With the higher dose, there is that potential for prolonged duration, which I think would be concerning for an unsuccessful. Obviously, if you have a successful airway placement, it's not an issue, but unsuccessful with no backup in the pre-hospital setting is a concern when we extrapolate ED data to pre-hospital data.
Even with 1 milligram per kilo, you're still looking at 30 minutes, 40 minutes of paralysis.
And that's why in the central sector, there's only one medical director that presets for ground units.
I guess I'm with Josh. We don't do the RSI at all, so I'll just defer to the people who are actually using it. I mean, are you anybody besides you guys using it, Gail? Or?
In the central sector, there are a number of agencies that do utilize use RSI. There's only one of the agencies that uses rocuronium. Everyone else uses SUX.
You know what they would prefer?
The agency that uses ROC is 1 mg per kg. That was their dosing. That was adopted in the central region.
So my thought is they're literally the only one in the state who uses it.
In the central sector.
Do you guys use it up there? Or?
1.5.
1.5. Oh.
But again, this is just a recommendation, so the local medical director could pick whatever dose they feel appropriate.
I'll let you guys know now between the two of you.
Not Linda like dials.
Hi, Brian. You know, this is a guideline. So if you set this at 1 and a medical director wants to do it at 1.5, then that would be fine, and that would be up to them. That way, it wouldn't make it, patently obvious that you're trying to recommend 1.5 if 1 seems better to most people.
I would go a step further, Brian, and ask this body if it would even be reasonable to omit rocuronium and keep it as succinylcholine, since that's, not only is there a minimum of agencies that practice this procedure, but there's a minimum of those minimum that use rocuronium. And therefore, is it more appropriate for this particular body to broaden the recommendations to the ones that are seen to be most standard throughout the state? And again, the individual medical director has the freedom in Arizona to go in whatever direction they wish. But the question is, what is the best position for this particular body to make recommendations? And would it be better to just limit it to succinylcholine?
Is this a guideline for pediatric and adult patients? I'm sorry for missing that.
Age greater than 15.
Okay. Yeah, because I was just going to say succinylcholine is obviously not recommended in children less than 8 due to potential for undiagnosed myopathy or so succinylcholine definitely has its downsides. It's nice to have an alternative, safe alternative, which is a non-depolarizing, but I will defer to the EMS experts as far as care.
I guess, like, if it's kind of you guys, mostly, I would say, you guys want it in? I mean, leave it in? Like, leave
My two cents would be so the provider can have their choice, because there's a laundry list of contraindications for acetylcholine. There's nine contraindications for acetylcholine, so leaving rocuronium as what gives the provider a choice between a skeletal depolarizer and a non-depolarizer. And so that choice is critical when you encounter some of the contraindications and stuff.
Can I just throw something in? Pre-hospital emergency care. So the Journal for NAMSP just had a position paper that came out in 2022. And essentially, I don't know, there was just one line on it with 2 references talking about if using rocuronium, intubation success is higher when using larger doses above 1.2. Just to throw that in.
So the consensus
To make it even more confusing, we all use 100 milligrams, let's be honest.
Right.
100 milligrams. So, I don't know where that falls in on this.
It's always 30 of etomidate and 100 of rock.
That's right.
Right.
In the interest of moving it forward, do we want to go up or down on leaving it as 1.5? Or what would be the next steps to move forward? I don't know, like monopolize because it's my Monday.
Vote one way or the other. Like I said, there's only none of the agencies that I work with utilize rocuronium, so I don't have a dog in the fight either. But I think just in terms of this committee making a recommendation to MDC, again, MDC gets the final vote, so they will be the ones that make the final recommendation based on this. But just again, the group's input to go forward to MDC. But yes, the vote would be good because we have quite a few to get through.
Hi, it's Brian. I'll make a motion. That we amend this with the AMT information and move rocuronium to 1 milligram.
All right, so there's an amendment on the floor to adjust this to 1.0 milligrams. Any discussion on the amendment? All right, hearing none, let's go ahead and get an up and down roll call vote, please. Shelley?
Okay. Start with you, Franco. How do you approve the RSI with 1.0 rock?
I will vote to approve.
Brian?
Aye.
Josh?
Yes.
Paul's not here. Shari?
Yes.
Garth?
Aye.
Mark Hanson?
I approve.
Jason Johnson?
Yeah.
Nat Shaw?
No.
Philip Hammond?
Aye.
Amber Wright?
Aye.
Heather Miller?
Aye.
Chester's not here. Erin O'Connor?
Yes.
All right. The majority is approval 1.0 rock.
Any
Hi,
further?
it's Brian.
Yeah, go ahead, Ryan.
So in general, trailing zeros are not really acceptable, so it would just be 1 milligram.
Correct. Any further discussion on the protocol, on the remainder of this guideline? Hearing no further discussion, can we get a vote for the rapid sequence intubation guideline as shown? All those in favor say aye.
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 Any opposed? Any abstentions? All right, the motion carries. We are moving now on to the section including epic traumatic brain injury.
this window?
Yes.
Sorry, Franco. I'm catching up slowly.
So we had asked Dr. Spate to review the EPIC TBI guideline and make some recommendations. So he did make those, and Shelley kindly has put that into a format so we can all see kind of the recommendations that he has included in red. So we can kind of slowly scroll through those, or slower. The slow roll.
Right?
As I'm sure everyone is aware, Dr. Spade is very passionate about this, and really this has made Arizona kind of a leader in a number of the journals and conferences regarding head injury care. So,
Can we go back up to the top for a second? I just wanted to make sure, do we use that abbreviation SAO2 throughout the rest of the document?
I think that's one of those global fixes I need to do.
Okay.
And change it throughout the whole document to SCO2. Is that what you're saying?
Yeah.
Okay. I have that down as one of my global edits when we're all done.
perfect.
And then I don't know that I've seen HF used anywhere else. I'm assuming that means high flow. I mean, is any, I guess from a practical perspective, I know that we approved that as a positive pressure adjunct. But do we need that?
He means
that here.
That's not what he means. Yeah.
Yeah, he uses that for,
He simply means 15 liters a minute.
Yeah.
Yeah.
I would say it's probably redundant. If we
Yeah.
put 15 liters, I think we could delete the high flow part. And not confuse it with high flow nasal cannula.
Yeah, I agree.
Maybe non-red breather at 15 liters per minute. Yeah. Make it more clear. And spell out non-red breather.
So you could probably get rid of all the dark text, right?
Wants to take over making of it.
Pardon?
What else do I need to edit?
Just spelling out non-red breather. I've got that as a mark though.
And then the changes that we're making now create a lot of redundancy with the bullets below. And there, we have a bullet that says BLS airway followed by another bullet that says BVM.
Those are technically two different things. BLS airways are technically a nasal or oral pharyngeal airway and could be a high gel, and then bag valve mask ventilation is what you attach to those airway devices.
All right, that's fair.
Scroll down a little further. I don't think he had any suggested changes to that. Don't see any changes there, but keep scrolling to the red. There's a few more into that section.
Hi, it's Brian. Since Untitled CO2 is now an STR for EMTs, do we want to just move that up there and put STR behind it?
Do you think we should copy it, put STR under EMT and keep it under paramedic?
Well, you know,
I feel like on
technically,
the other
one of these is supposed to build onto the next one, but
I feel like on the airway ones previously, we put it in EMT and delete it from paramedic because they're supposed to knock on, yeah.
That's cut and paste. Google product is very jumpy.
This is Gamer. Just a technicality up there in the EMT box. Some of those skills are all the way across, correct? For children as well as adults. And then the, what I'm referring to is, well, basically everything in the adult box is all the way across, and then with children-specific parameters. Just a technicality.
Data. Sorry, which elements do you want on for both?
I think what Dr. Gamer is saying is that everything in the left-hand box should carry across for all age groups. And then as a separate matter, those ventilation rates are pediatric only.
Exactly.
Okay. I'm having trouble merging the cells, but I can make the edit from the recording.
And then also as a matter of clarification, the red colored font that's shown right now, I'm assuming that if the panel agrees that that language is to be kept, that'll all be changed to black, non-bold. Is that right?
Correct.
Okay.
hi, it's Brian. I'm confused about this pediatric move. We do keep pediatric stuff in a separate box with the teddy bear, don't we?
We do, Brian, but the proposal is to move everything on the left as an across the page comment. And then just below that, where you see that darker blue section with Shelley's personal notes, move those airway ventilation rates to the right side separately there and keep the left adult side blank.
Okay, so then these are the rates that we are supposed to be assisting ventilations, right?
Correct.
So that's different, as Dr. Gaither noted, that BLS airway maneuvers is different than whether we're ventilate as indicated, seems like, or BVM as indicated, rather than BLS airway maneuvers with those rates.
Yeah, so if I understand correctly, you're thinking that wording at the top of the pediatric section should be adjusted to refer to BVM rates rather than BLS airway
Maneuvers.
Yeah.
Correct.
Yeah, that's very reasonable. Anything else on this one? And so in summary, Shelley will make adjustments to move the BVM pediatric rates to its own box just below. Per Dr. Gamer's recommendations, all of the airway breathing bullet points will be formatted across the page as they apply to both pediatric and adult patients. All the red bolded font will be changed to standard font as shown. We added the STR for EMT comment under the Untitled CO2.
Are all those boxes going to get turned back to white also without the highlight?
Yeah, I think that'll be one of the global edits, will be to get rid of the colors,
Okay.
aside from the scope colors.
Could you scroll back down to EMT real quick? Thank you.
Is there a missing teddy bear there?
So all the little typographical stuff, we will work on that piece. The goal for this committee is to really focus on the clinical piece in the interest of time. So we will make sure we go over all of the typographical components, but that component, let's try to focus more on the clinical. We will make sure there's teddy bears and everything in the right place.
That'll just be what we call from now on. That's
Yes.
the teddy bear.
It's the teddy bear, and we will do the teddy bear as offline.
This is Philip. I was wondering if we can clarify or shorten some of the language in red. For example, in that first bullet, the attempting to keep SaO2 as high or as close to 100% as possible. Can we just say with a goal SpO2 of 100%? Similar with do not hyperventilate, can we just say avoid hyperventilation? So in that first bullet, attempting to keep SaO2 as near 100% as possible, can we just say with target SpO2 of 100%?
Everybody like that?
Yes.
That works.
What was your other suggestion again? I'm sorry.
If you scroll down, it was during the hyperventilation or during the secondary airway portion, there's a reference to do not hyperventilate. So can we just say avoid hyperventilation if you keep scrolling down slightly to the next box, I believe. Keep going right there. Do not hyperventilate even before advanced airway is obtained. Can we just say avoid hyperventilation?
All right. Everybody's happy with this?
Any further discussion? Okay, not hearing any other commentary. All those in favor of the traumatic brain injury guideline, EPIC TBI, as shown with the edits as discussed, all those in favor say aye.
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 All opposed say nay. Any abstentions? Thank you. The motion carries. The agenda is showing the next section is general medicine with Dr. Gaither.
Dr. Ketchum, I really think we need to go backward and do airway management. Like the minutes show, we had 2 left on math. We did RSI, and I think we're needing airway management. Am I wrong?
I thought RSI was all we had left.
Yeah, RSI was the only one we haven't touched as well.
I'm wrong. It's on the record, I'm wrong.
We can always catch up. We feel we need additional.
I don't care. I can take it. All right, Franco section with cardiac.
I'm showing the agenda showing general medicine next, or does it not matter? I'm happy to do mine.
Oh, yes, please, we can do gen med. Let me do file. You want to start with,
Want me to start with this one? Yeah, I can start. This is easy. Just because there's so much triage going on, I figured we'd clarify NCI triage, not formal ESI triage. That's all.
that's the one edit.
Whew, man, I'm changing a lot.
I disagree. We should not.
I do have a gavel, since Franco's not here. Gavel, Franco, can I use your gavel for you?
Gavel away. Yeah, so any other discussion on this adult and pediatric universal care guideline?
Page 2 is still appropriate.
A few things changed.
Okay, great.
All those in favor with the single edit as shown, say aye.
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 Any opposed? Any abstentions? The motion carries. Thank you.
All right, syncope, pre-syncope. Again, I don't actually know if there's anything here. I haven't looked at these in like 4 or 5 months, so I honestly have no idea what's changed. Is the green changed or not changed?
Really?
Yeah.
All right, I changed nothing.
You have a comment on the
Oh. Oh, this is not an ESENSO guideline. Oh, man. Okay, I take that back. I should really read my own notes. Yeah, I mean, it's not an ESENSO guideline. If you guys want a syncope guideline.
I like having it in. I know our EMS runs on enough syncope. It's nice to have them have something.
Okay. I'm good either way, Clara.
I don't think there's any actual orders in this one, though, really.
No, there's nothing to do.
I mean, there's nothing to do in it. It's really just educational points about which guidelines to look at, which are all of the arrhythmia guidelines. But fairly just points you to those.
I mean, the one counter argument is it does say perform a 12 lead, and sometimes as a medical director, it's good to have that in writing. I totally get that. So,
Yeah.
I second what Dr. Gaither just said. This comes up in quality reviews all the time. That somehow, especially pre-syncope, is always felt by a lot of pre-hospital providers as being a less problematic chief complaint with less morbidity, and that's just simply not true. And so I think even if all this does is tell you to get a 12 lead, it's good to have that memorialized.
I'm happy to withdraw that recommendation.
Any other comments on this page? Without hearing any additional comments, we'll go ahead and move to a vote. All those in favor of keeping the syncope pre-syncope as shown, say aye.
Aye.
Any opposed? Abstentions? All right, the motion carries.
All right, next is suspected stroke.
So in red, the changes, I added in difficulty speaking as the includes. I think that was, before it was just slurred speech. Obviously, simple change. The minimize on-scene time and ensure rapid transport to the stroke center as outlined in local protocol or medical direction. I think this is something that most of our people, if they don't have these in their system, have no idea what this means. So at least for Southern Arizona, we don't have all of those. So.
And we have different ones too. We have a primary stroke center plus, and yeah, we have some other ones from other accrediting bodies that we have allowed to be destinations for stroke.
On that topic, it seems to me like there was a statute or rule passed related to stroke and requiring that these particular definitions are used for EMS to decide. So my question is, if we take it out, are we going to get crosswise with that? I don't remember the numbers of whether it was a regulatory maneuver or a statutory maneuver off the top of my head, but we were looking at some of our treatment guidelines, and I know it's been 6 months ago, 8 months ago, and I know I was looking at those types of definitions in that area.
So I think, Brian, it is a good point. There is, I believe, statute that does outline that. However, it states that there's a protocol in place for EMS. Because these are statewide, it does become a little bit more problematic as many parts of the state may not have any level stroke center, or if they do, they only have kind of more of a typical primary stroke center as opposed to a comprehensive stroke center. And so I think from a pre-hospital setting, from a statewide level, if we leave the terminology local protocol / medical direction, then that does fall back on each entity if they have more advanced capabilities available in their area to delineate that for their EMS providers. I'm not a lawyer. I will finish my statement with that. So.
And I like the idea of just keeping it simple. Yeah, because the same way I would get that question all the time from our EMS. Like, what does all this stuff mean? Doesn't mean anything to you. Just bring them to the hospital. You know.
So the one feedback, just kind of go back to the title of this. This was some feedback that we got from many EMS providers. Just scroll to the top. Is that when they are searching for some guidelines, most things are, this is suspected, and so the thought was to just change it to stroke / TIA, adult and pediatric versus suspected, because you're suspecting it regardless. We don't have a confirmatory tool in the pre-hospital setting like a CT scanner, but it kind of is easier for them to find and utilize if you take away suspected.
I like that.
So then my next question will be, is it appropriate to use the term stroke center down there at all? those are levels of stroke center. Should we have something else stated there rather than that then?
I do have the regulation in front of me if you guys want to hear some legal jargon.
Yes.
So the regulations under Rule R925-602 say that the council shall ensure that there are protocols in place and that they will take into account the location of emergency receiving facilities that are listing out as they were acute stroke-ready hospitals, primary stroke centers, and comprehensive stroke centers.
I think that, just so quick, or Dr. Bradley was saying, is that you're now saying medical directions taking that into consideration, so it's up to them to direct their crews where to go.
Okay, with that, if you want to say, I mean, the term we use is closest receiving facility, you can change that in there. I think stroke center is fairly well recognized as someplace that takes care of patients with strokes. But
I mean, I think for like Maricopa County, there would be no, I don't think any jurisdiction that would take a patient to a non-stroke center because there is an abundance of stroke centers. You know, so I think just that terminology is pretty standard. So I think to get away completely from stroke center in that would probably be going a little too far as opposed to trying to streamline this and say stroke center as outlined by your local protocol direction.
And the regulation goes on to say, taking into consideration capability of any other type of emergency receiving center and then duration of transport. So I think you're good here.
all right, then, only a couple other notes on this, things that are not there. There's a note over there on the right. The first one is that the central region moved the signs and symptoms, an increased risk of stroke up to the top box. I did not make that change. I just wanted to be transparent. That wasn't there. The other little more clinical note, the SIMSO includes sudden onset of dizziness and vertigo as a stroke symptom. I chose not to add that in. And you can see the second comment down there is some of the prevalence of isolated dizziness as a stroke symptom. The prevalence is very low. It's about 1% of those patients with acute dizziness have a stroke, so fairly low. That's why I recommended we don't put it in there.
It's a very common chief complaint.
Really common.
And I think for any hospital that has included dizziness in their stroke activations, I'm sure you have, I know I felt when I worked clinically, your stroke activations have skyrocketed based on that addition. So I think from pre-hospital setting, especially when you go to an area that you may now be bypassing multiple hospitals, for flying a patient, this may have more harm than benefit. So.
I agree.
Any other comments, Dr. Gaither, on this one, or have we run through all the edits?
Those are all the edits. I'm sorry, yes.
From the body, any other comments or feedback? And hearing none, all those in favor of approving the now titled Stroke/Transient Ischemic Attack Adult and Pediatric Treatment Guideline, all those in favor say aye.
Aye.
Aye. Aye.
Aye.
Any opposed? Any abstentions? All right, the motion carries.
All right, next, turning our attention then to anaphylaxis allergic reaction, adult and children. A few just formatting things that I changed to reflect those made by the central region. There's only really two substantive changes on this one. The SIMSO does not have steroids for treatment of allergic reaction. That is obviously within the scope for us, so I added those in here. Methylprednisolone 125 and dexamethasone 8 milligrams. I've put the terminology consider administration of one of the following.
You want to put pediatric dosing in there?
Oh, I didn't do that.
So, one big change that was made in the central region for the epi dosing for, repeat was that the repeat was, based on recommendation from some of the allergy specialists, was to make the repeat dosing every 5 minutes instead of every 5 to 15. So if you had a true anaphylaxis, that you're not waiting a 15-minute mark to repeat the dosing, that it'd just be a clean 2 5-minute repeat as needed. So for both adult and pediatric, where it's epinephrine, just a little higher up, especially. So the repeat dosing epinephrine can be repeated to 5 minutes, so every 5 minutes instead of every 5 to 15.
Do we have anything in there about EMTs as an STR to do the IMEPI?
I didn't put that in.
Oh, yeah, the prepared kit.
It's in there as any patient with concerns for anaphylaxis who is, no. That's not currently within the scope though, is it? That got approved, sorry, yeah, no, my bad. Yeah, that should go in there. You could just move the,
But
the
just
AEMT
yeah, the
box.
AMP, and then just put STR after it.
Yep.
Yeah. And you might say something about
It actually
prepared kit.
just move the AEMT line down.
Yeah.
So it's above the start of the box.
So the requested edit is to move the AEMT epi stuff up.
Correct. So it would read, if signs of anaphylaxis and no auto-injector available, administer prepared epinephrine or prepared kit epinephrine. And the same thing at the bottom, and then STR after it.
I'm trying to remember the rationale, because I feel like Tony Gross had weighed in on that pretty heavily when we took the steroids out for anaphylaxis. I've been trying to go back to the NESEMSA to see if the rationale was in there, but I remember the last time we took it out based on some specific guidance that it comes from NESEMSA on that. But I don't recall the full conversation.
Dr. Bradley, I think it's going to come down to what is truly impactful in survival, and neither diphenhydramine nor steroids in the acute phase are considered to have an impact on survival ultimately.
Thank you. I did remember there was something, I couldn't remember the details, so that does jar my memory. I think historically, pre-hospital people tend to give a lot of Benadryl and Solumedrol, and kind of epinephrine was really far down their mental pathway, and so part of that rationale was having the epinephrine and not even having the steroid, because it doesn't change that acute outcome, but people tend to want to give the steroid. So for true anaphylaxis, that was kind of the rationale. I think that why, I just double checked with them, so I think that was why they took that out too.
Yeah, I would counter argue that this is an allergic reaction guideline, not just anaphylaxis. So
Then on that same thought, is Benadryl or over-the-counter meds, PO, under the EMT scope of practice?
Not the Benadryl, only for the pain medication.
Oh, it's just the Tylenol ibuprofen, okay.
There's a comment in the box reminding the body that albuterol and ipratropium is also in scope for, I'm assuming, basic EMTs.
Oh, yeah.
that is true.
So under the AEMT, you scroll down, right where it says albuterol, that can go up.
under the epi dosing.
Above epi or below?
Below.
Below the epi in the EMT, yeah, there you go.
But then we need a line over the nebulized epinephrine.
I don't know any of that's nebulized. So keep albuterol nebulized in the AEMT.
No, you put there, it just needs an STR at the end.
Oh, sorry. For kids too.
Yeah, so that would need to be across the whole,
Visualize it.
So we would need to put something above the nebulized epinephrine dosing.
I need to remove it from AEMT?
No, it just no longer has the instructions if respiratory distress breathing, because that was below the albuterol bullet.
be in both sections.
Yeah.
So you could remove that from the AEMT because everything builds downwards.
Not the epi though.
The nebulized oh, excuse me. Never mind. Are the steroids going away? Is that what that outline is on those? Because neither one of those are in the AEMT authorized list.
Oh, so if we want to use steroids, we need to put them down in the medic section?
Yep.
Okay. So Shelley, where it says, just the second bullet down, needs to get that whole, there. From there down needs to go into the paramedic section.
At the top?
Below diphenhydramine.
Below?
Did we want to give peds dosing for that as well?
Mm-hmm. I don't know what's for peds dosing.
Running out of room on this page.
We'll be able to do, I think, a little bit of editing on that piece to go over page wise. But
Dosing, well, if you do 0.2 mg per kg, then you get a huge ass.
What else am I supposed to be doing?
sorry, I'm looking at the desk, I'm sorry, taking through.
Oh, methylbrand, yeah. Yeah, we'll figure it out. 2 mg per kg, what's the dex one? Yeah, exactly. No, they told us it's 8 for an adult, I think it's 0.1. Actually, I think it's 0.15. Okay. So this may be something we can work on offline. I believe the methylprednisolone dose for a child is 2 mg per kg. And I believe the dexamethasone dose is 0.15 mg per kg.
You said 1.5?
0.15.
Yes, methylprednisolone is, if we wanted to match the bronchospasm has, across the board for both, the 2 mg per kg, max dose 125, and then dexamethasone 0.6 milligrams per kilogram, max dose 10 milligrams.
Okay.
and what. That's Bronco.
Anything else I was supposed to try to edit?
Is the group satisfied with the edits as shown, or shall we perhaps table this to have one more look at it before we vote and give the Dr. Gaither's team a chance to review this one more time offline?
I think we're okay with it as long as you guys double check the dosing.
Yeah.
Okay. With that said, I'll ask for a vote to approve the anaphylaxis and allergic reaction guideline as shown. All those in favor say aye.
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 Any opposed? Any abstentions? Thank you. The motion carries.
All right, altered mental status, next, is that right? Perfect. I just got rid of some stuff that I personally thought was kind of silly. Acidosis, metabolic disorder, change intoxication to toxic ingestion or substance use. Narcan is no longer an STR, I believe, so I got rid of that. I just moved the treat shock up to AEMT.
Any additional comments or suggestions?
Can you scroll back to the naloxone and EMT? Okay.
Well, except that if you have that in the EMT, you have the IM injection in the EMT section. Right there.
They can give it IM, I believe.
Can I do now?
Yeah.
Okay.
This is Erin O'Connor. I just had a question. This is under altered mental status, is that correct? So,
That's correct.
So really naloxone really shouldn't be administered unless the patient has respiratory depression and CNS depression or decreased level of consciousness. And I know I've had this happen, actually, folks walk up to paramedics and say, hey, I don't feel right. And they're like, they're actually methamphetamine intoxicated, and they get naloxone administered to them. And then this protocol gets cited. So I really think this is a great opportunity to fix this problem. We have an overutilization of naloxone in inappropriate patients. And I think this might be part of our issue.
Yeah, I think I was actually going to bring up that statement. This has been brought to me a number of times of really some of the education that was done when we developed naloxone for law enforcement initially for EMTs was really heavily pointing out that we want to treat respiratory depression and not someone who is quote unquote high. So if someone is, awake, but sleepy or drowsy, but has adequate ventilation and oxygenation, we don't necessarily want to give them naloxone and potentially precipitate withdrawal in an agitated patient. As we have seen kind of more naloxone out there, both bystander, law enforcement, et cetera, there have been patients that are getting large doses that are requiring then sedation and subsequently because the patients are very agitated. And so I think maybe an opportunity for some clarification that the naloxone is not necessarily just altered, but for respiratory and CNS depression, as this is geared towards EMS providers and not simply law enforcement, the layperson.
Maybe just adding a line like that right before the naloxone that says if signs of respiratory depression or something like that, then where you took out that line right there where it says STR.
So in front of naloxone, say for respiratory and for CNS depression.
Or either before or after, it doesn't matter for respiratory depression. Yeah.
That is something that actually from the Opioid Fatality Review Group here at ADHS, an email that was just forwarded to me yesterday was kind of addressing the same request as well.
In the edit, please.
For respiratory or CNS depression.
And I would also venture to say the whole name, the altered mental status, is really not helpful in any medical setting, right? Like, because we don't know if that means you have CNS depression and or excitation. So I also think the name of this particular guideline could be problematic and not. And I think we're lumping too many things into the same nebulous pot.
So your recommendation would be to change the title to something like suspected overdose or something like that?
We have an opioid poisoning overdose guideline.
Right.
Yeah, I mean, I think if you have CNS depression guideline, or if you have a agitation guideline, that might, kind of parse out those two things. But given, like, if you look at the top of all these different diagnoses that we have, and then we scroll down and all we have is naloxone in there, it's really very confusing. And, whether someone's post-ictal and CNS depressed or whether they're opioid intoxicated and CNS depressed. I mean, I think naloxone being used for anything other than, suspected opioid intoxication with CNS and respiratory depression is what we really need to kind of take the opportunity to drive home and protocolize.
So when I go to Symptom, so Symptom does have an altered mental status, and then this altered mental status kind of really is getting into assessing the airway breathing, GCS, APCU, check of blood sugar, and then it starts referring you to other guidelines. So it refers you to glucose if you suspect hypo or hyperglycemia, refer to naloxone if an opioid overdose if you suspect that. So they actually don't list naloxone in their altered mental status guideline. It refers you over to the opioid overdose guideline. So that would be a way to potentially, I think, address some of this, which is to say, altered mental status can be a number of things. Let's do just a good global general assessment, make sure you check the blood sugar, and then go to the respective appropriate guidelines. So if you suspect opioid overdose, then you go there as opposed to having this automatically being on the opioid overdose guideline. That would be more in line within the Symptom version currently as well.
Yeah, I do think having the altered mental status guideline is useful only because it is a presentation with a very broad differential, and if they're using this as a reference, it pulls together some of the more common etiologies for altered mental status and gives them that reference. So for that reason, I think the guidelines are useful. I wouldn't be opposed to removing Narcan from this specific page, but.
Right. And I'm the same way. I kind of like that because with our regular full-time active crews, it's not a question, but we do have some very small rural agencies that are staffed by volunteers. And when they go out on a call, they literally take out the protocol book and read through and goes, oh, okay, I should think of glucose, because it's not something they do all the time. So I like what Amber said, just maybe kind of keeping it in there. Maybe, if we need to move to the Narcan out of it and just refer over like you were saying. But I still would like to keep it in there as a general information form.
I'll echo the comments made, especially of Dr. Connors and Dr. Bradley's. You know, I'm also looking at the NASEMSO guideline, and it really does act like a hub and spoke type of commentary, rather than focusing on any one treatment like our current guideline seems to show. It pulls together a differential diagnosis. It calls to attention the most critical assessment details that think about, which goes to Dr. Johnson's concern, but then it really just has a bunch of hyperlinks to the appropriate treatment and interventions without over-emphasizing any single one of them. And I think it would be easy enough for this page to be formatted in a similar fashion.
That's my motion.
All right, so.
Can we do that?
So summarize, if you can just scroll down, Shelley, to kind of the meat and potatoes of this guideline, the EMT section there. So it sounds like the first section, universal care through temperature, probably stands as is. And then the naloxone component would be deleted, as we already have a link at the top to opioid overdose, which would then take you to naloxone dosing. That whole row.
Maybe just add a bullet point under like the sepsis one that's like, if suspected opioid, then it should hyperlink you to the other one.
Well, as was put in the comments just now, we have a poisoning overdose universal care.
Yeah.
Right. Yeah, that's what that should say.
Basically, all of the naloxone stuff would come off. We would still keep shock.
I mean, you can almost just put everything under EMT, since everything feeds downward, and probably would be wise to mirror the hyperlink list as shown in the national document.
I think the fluids would need to stay where they are.
Repeat what you want me to type again, please.
The stuff on the paramedic on the right-hand side there, that's all would fall under EMT as well.
I guess I would ask if you wanted to leave one intervention in, I would think impaired glucose administration would be one that you might want to highlight. But I don't know if that makes it then confusing, if you just want to leave all interventions other than general assessment out.
There is a hypoglycemia guideline.
Yeah, and I think that's the one where you would just link to it and use this, like Franco was saying, where you have a central place and you just click onto the places you need to go.
I think that consider IVIO doesn't need to be on the PED side. That could be just for both.
Right.
There's no reason to split it.
Excuse me.
And I will just put a quick time check on the schedule here for everyone. We are at about 1:25. We do have our PACES meeting started at 1:30. So if we could potentially finalize this one and then just quickly discuss potentially E on the agenda, but I don't know that we'll have time for that.
Quickly.
Very good.
Just to restate the obvious here, these are triage, treatment, and transport guidelines. This has no triage, treatment, or transport recommendations included in it. It's purely educational.
Well, I would argue that every hyperlink is sending you to another treatment.
Yep, same with the front page. But that's my... There is nothing unique on this page any longer. Which is fine. I don't care at all.
Sounds like you cared a lot.
I really don't, but
Really don't. I would say that this does match the NASEMSA guidelines, which does have an altered mental status and is a frequent source of chief complaints for EMS providers. So I think it is a good point that we had probably too much emphasis on naloxone for an altered mental status guideline. But this does at least point to if someone's altered, check a glucose. We've all probably made that mistake once and missed a hypoglycemic patient. So that alone, kind of like our 12-lead alone for syncope, is probably worthwhile for this.
Right.
Anything in the chat that needs to be addressed?
So I see EMTs can give IV fluids as an STR. I think we will need to look at the formatting of that. My only concern is when we start listing things only under EMT as STR only, does the paramedic who doesn't know what an STR is, because that's just their scope, do they question whether or not that's for them to do? Because it's listed as an STR, but it's not an STR for others. Probably a cleaner way would be STR in the EMT section, and where it's just on scope, you just list it without the STR. So one of those formatting things, we will look at both and just make sure that from a visualization, as people look at that it's more clear. But yes, thank you, Kyle. It is, you are correct, EMTs can as an STR give fluids and start an IV.
I now have this presentation.
Franco, do you want to call for a final vote in the interest of time?
Sure. So all those in favor of approving the altered mental status guideline as shown with the edits as described. Yeah. Aye.
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 Any opposed? Abstention? Okay, the motion carries.
And Franco, I know you have to get off at 1:30 as well, so I think we will have to table the rest of the items. We will schedule another meeting, hopefully within a month, to kind of keep going here. But if you wanted to go to the item number 6 on the agenda.
Yes, it's kind of past my hard stop time. So with the committee's permission, I'll ask Dr. Rice, our vice chair, to conclude the agenda.
No problem. Got it. Thanks, Franco.
Thank you.
Thank you, Dr. Simpson. And then the last item on the agenda will be,
I think we're at agenda items and call it public.
oh, great. Agenda items for next time. In the interest of time, please send any thing else to Shelley. I think likely we'll be still working on this. And then any other calls to the public.
Yes, this is Sandy. Can you hear me?
Yes.
As you know, we have a lot of paramedics that are now working in the pre-hospital realm. In the hospital. We have several at our facilities. They have brought a list to me of medications that they feel they would be highly appropriate for them to be able to give in the hospital setting. And I will, if it works for you, I will submit that to Shelley. And if you would please look over those to see if these can be addressed at the next meeting.
Yes, we will. So we will definitely add that to the agenda. We are a little bit of a time crunch to get the TTTGs updated, so it will definitely be kind of added, but with the caveat that we do need to get the TTTGs updated for the next calendar year.
Okay, and the other thing is, and this probably falls under the TTGs, is the diltiazem, making it required instead of optional in the drug box, because it is in our protocols to administer it for tachycardia, for narrow complex, and it's listed as an option. It doesn't matter right now because we can't get any diltiazem, but for future reference. That's it. Thank you.
Thank you.
It's Brian, real quick. We're not going to do another special meeting so that these are done for September's MDC.
Yes, we will be.
We will probably need to do one for sure.
Yeah, okay.
Yeah. Or two, yeah. Come on, guys. Okay, with no other public comments, we will go ahead and adjourn the meeting. Thank you, everyone, for joining.
Thank you. Bye.
Pink Street over there.